Um, so it's with great pleasure that we have today's presentation on the diagnosing central auditory processing disorders for those with ADHD and ASD. And this presentation came as I was seeing a patient in my clinic, and I was reviewing the testing, and I thought, and the testing showed that the processing speed was about 15 points lower than everything else. And mom said to me, she said, is there anything we can do for that? And I'm thinking, well, I don't know. I've already, his kids on ADHD, he's taking stimulants, he's gotten all the 504 accommodations, and so I posted on Facebook on the physician women's group, hey, what does anybody think about this? And that's where I got Dr. Contractor's response to me saying, hey, have you considered central auditory processing disorder? And it was something that I had heard about kind of in passing, controversial, and didn't really know where to go and gather more information about it. So it really piqued my interest. And with that, I want to introduce my friend, colleague, Dr. Layla Contractor. She's a board certified psychiatrist with a unique journey that blends traditional and integrative psychiatry. Inspired by her grandfather's passion for patient care in India, she's pursued psychiatry at the esteemed Western Psychiatric Institute and Clinic, working alongside leading researchers in trauma, adolescent mental health, and cultural psychiatry. She's also worked a decade at Kaiser Permanente, and then her personal health journeys have led her to the power of integrative medicine, where she's then learned from Dr. Gabor Mate, has done the Integrative Psychiatry Institute Fellowship, and always learning something. Every time I talk to Layla, she's always telling me something new she's curious about. So I know that if she's working in this area, it is something definitely that we should be knowing about and putting our attention with. And so she has invited Dr. Maria Abramson to join us as well, who is a leading expert in audiology and has dedicated her career to advancing the diagnosis and treatment of central auditory processing disorders and self-perceived hearing differences or difficulties. Her research and innovations have led to the development of the patch discrimination test and the basic auditory training program, both that are widely used in treating auditory processing disorders. She also contributed to the development of oral rehabilitation of interoral asymmetry therapy, that's a mouthful, and her clinic has been serving as a beta site testing in 2016 and 2017. She's recognized as an expert nationally, and it's with great excitement that we have two people who are going to be collaborating and sharing with how they work with individuals with auditory processing disorder. So with that, I pass it over to our dream team.
So good morning, everyone. And again, it's just such a pleasure to be here. So I am an audiologist in private practice, and I want to thank Dr. Contractor for inviting me. So we have shared patients together. And Lila, do you want to talk a little bit here of how we happen to come together?
Yeah, so the way I came to central auditory processing disorders, I have three children, and all three of my kids have auditory processing disorders. They all have dyslexia. Two of them have vision processing. So I became really interested in that from that perspective. One of my kids has where the word sounds so similar to her that we actually thought she was being really defiant and not listening to us. She's neurodivergent. My son, oh my gosh, he talks loud all the time. Mom, turn the volume up. Mom, turn the volume up. And he started out seeming like a superstar academically and then lost complete interest in reading. And then my youngest was actually globally delayed, had multiple issues. And what we found is that we had to give her forever to answer anything. So her processing delay, and the siblings, we had to be like, they get so irritated with her, take forever. So that's how I came. And then I ended up in a conference with Dr. Peter Mundy. He's at the UC Davis Mind Institute. In 2018, he was the president of the International Society for Autism Research, and he discovered that joint attention is actually lacking right? Or there's struggles with joint attention for those individuals on the spectrum. And I was lucky enough, I got to be in a small group with him. And when he heard about my stories about my kids, he turned to me and said if he had to do his entire research career over again, it would be on central auditory processing disorders. And so I was hooked then. I was like, if this guy is like such a big wig in the field of autism is saying that this, and what I've seen, I think as integrative psychiatrists, we're always looking at what approaches can we use to help our patients, right? And often non-medication approaches. And this is something I come to time and time again, and especially as a child psychiatrist with my younger patients, this has been like, oftentimes they don't come back to me. Once Maria sees them, they often will not come back for medications because a lot of times their problems are taken care of, or I've at least delayed when we start the medicine. If, but what I've seen in my patients, once they get the central auditory processing disorder treated, is increased in reading speeds. I just had a kid that Maria and I both shared yesterday. I see decreased hyperactivity, decreased defiance, a significant decrease in anxiety, depression, anger, increase in compliance. I mean, a lot of times these kids are not processing information in a way that we think they are. And the biggest one is there was a patient who had a 30%, 30-point increase in IQ. So these can be
And they're
really
happier too, right?
And
Lila,
they're-
wouldn't you say they're happier people when they're done?
They are, and so are their parents.
Mhm.
But I'm going to let it go ahead. But so this is where I really use this as a tool. So if any kid comes to me really with ADHD, autism, and especially with dyslexia, with 90% of reading really being auditory, I really try to convince the parents to go see Maria, because this is, again, another way that I can help these kids be on less medication. And then for those of us who are in psychiatry, whether they're kids or adults, by the way, because adults can still get this treated, these are our families or the kids where you're like, the medicine is not a slam dunk, right? You know, we all have those where the medicine like changes their life. These kids, it's not really that. It makes some modest improvements, but there's something that we're missing. And you're usually on neuropsych testing, you can see it, and it's the processing speed. Go ahead, Maria.
All right. Well, thank you so much. And like I said, I'm just so happy to be able to spread these little tiny seeds to you because I think that it's going to be a great resource and tool in your toolbox. So today, when we discuss central auditory processing disorders, we affectionately call it CAPD. I'm going to go over what it is and the comorbidities associated with it, that we can effectively treat it. And we will look for some case studies and then what the improvements are with our patients. So to begin with the auditory system, the way we hear, the auditory transduction process is first the outer ear collects the sound, its acoustic energy, and then it's transferred to the middle ear where it's a mechanical transformation of sound. And you may see children there who've had lots of recurrent otitis media or fluid behind the ears. Then we have a hydraulic transformation in the cochlea where the hair cells brush against the tectorial membrane, and then boom, the electrical spark. And so our whole auditory system is a series of electricity, neural impulses that go all the way up to the cortex. And so when we look at all this electricity now swirling up in our brain, uh, we audiologists can measure them electrophysiologically with potentials, but we name them functionally so that we can address therapeutic interventions for them. So the first is this pitch discrimination. This is a test I wrote and published in 2016. And basically this is, can you tell that one sound is different from another, like Roadrunner, beep, beep. Are they the same or different sounds? And all of speech and music is comprised of only three acoustic ingredients. Like if I was to make cookies, I would have to have sugar, butter, and flour, right? So by your understanding me, you have three acoustic ingredients: loudness, you hear me, pitch, and timing. And pitch and timing combine in very unique ways to form our perceptions of words. So evaluating pitch discrimination is a pretty important fundamental decoding skill, and this test can be done as young as 4 years of age. So that's kind of exciting too. Next is binaural integration. And binaural integration means that you're using the auditory information from both sides of your brain together for comprehension. So the right side of your brain is holistic, mathematical, visual, emotions live there. And then via the corpus callosum, it transfers to the left hemisphere. The left hemisphere is verbal. The left hemisphere is analytic, sequential, timing, all that discrimination happens in the left hemisphere. And really, you need both to understand. And we'll see in a few more slides here that when we have a developmental mismatch, we do have central auditory processing problems. Binaural separation is a cousin to binaural separation. So we have both sides of the brain, but now we have to suppress information one side and just focus on one side, or we have to pay attention here and suppress that. So can we do this suppression? And you'll see, I'm sure you already noticed in children with ADHD, difficulty with suppression of unwanted stimuli. Temporal ordering and sequencing means recognizing pitch patterns, like so I mentioned earlier pitch and timing combine, and next to discrimination, this is one of the most fundamental skills for decoding for both listening and reading. Actually, when children are born with hearing loss, next to fitting them with hearing aids and discrimination, this is the next skill we teach them, because phonology, the sounds of English, sit on this. They sit on this pitch and timing changing. And we use tones to evaluate these processes, because by the time a baby is 9 months of age, they recognize the phonological contrast of their language. Actually, my thesis advisor for my master's, Pat Cool, demonstrated that. And so, for example, a 6-month-old baby, a Japanese baby, hears the difference between rice and lice. But by the time that baby is 9 months of age, it doesn't recognize that contrast because it's not phonologic for them, okay? So that's why we use tones, because I'm the we, because we want to look at that acoustic or auditory piece. All of those auditory pieces have to go on the superhighway to the brain, because not for a minute is your brain focusing on the decoding. Your brains are focusing on content. Auditory closure means if part of the word is missing through some type of distortion, like temporal distortion or frequency distortion, can the listener fill it in? Auditory figure ground means being able to listen in a background of noise. And what we often refer to there in noise is if signal to noise ratio. So if this is the signal and this is the noise, how much more do you need the signal out of the noise to be able to accurately recall? And studies have shown that background noise do impact auditory working memory. So that's a big deal as far as being able to remember that. Excuse me. Okay. And finally, the last process here is temporal processing. I'm really making an effort to talk a lot slower than I usually do. How am I doing, Lila? Because when we talk really quickly with new information like I'm doing right now, it's hard to understand that. And so those are the processes. Now, this is the analogy I like to do. I actually have some little show and tell here. So I want to do an analogy of central auditory processing, of think of your brain as a sponge, right? So I have a sponge here, right? And so if I have no central auditory processing disorder, water's going to go into this sponge and you're going to just absorb it. But if we have a severe central auditory processing problem, I have a rock. I am pouring water on here. Here's the sound, but it's not going in. And so that creates a host of problems. Now, that is a severe example. Sometimes we have a situation, there's two hemispheres, where one hemisphere will be much better than the other. And then this also creates a slow, what you mentioned, processing speed. Like you ask the child a question and then you're waiting and you're still waiting for the answer. Not that they can't do it, but say, for example, a moderately severe processing problem would be, instead of water going in, it would be like syrup. It goes in, but it takes time. And the difficulty with that is the listener continues to talk. So I took note when you mentioned that they said central auditory processing had controversy. And so in 2018, I wrote this summary paper regarding what everybody agrees upon in central auditory processing. And, in any field of study, there's always going to be some controversy. That's how we learn. We have different points of view and we move forward, right? But I'm pleased to say that I didn't get any letters to the editor. No one said disagreed with these 5 points. So I think we can plant these little seeds of safety. So number one is the auditory system is composed of the ear and the brain. So the ear is considered the peripheral system, and then obviously the brain is the central system, and we hear with the brain. There are two strategies that we use when we're doing auditory processing. It's called bottom up, from the ear to the brain. For example, for your birthday, I baked a, you have to hear that last word. Oh, excuse me. No, you know it, don't you? Cake. Because that's top down. Sorry. That's a top down processing. For your birthday, I baked a cake. Now, for a bottom up strategy, it would be Mrs. Jones was thinking about the, you have to hear that word because there's nothing in the sentence that gives you any clue. So we use both the ear to the brain and then the brain to the ear, and they work simultaneously. The second principle is that auditory signals are transformed into electrical impulses. And we know that, our heart's electrical, our lungs are electrical. And so we measure this electrical activity. And each process has a unique neural signature in the brain. The next is central auditory processing is fundamental to listening, which is key process in communication and learning. And this again is known to be true. We only learn two ways in school, through our eyes and our ears, and most of learning in school is auditory. Treatment for deficit-specific weaknesses of central auditory processing has been demonstrated to be effective, and you'll see evidence of this. And it just makes me so happy to be able to share this with you because it does change people's lives and it does help them. And kids, I need a scale, help me, of happiness for young children because they are happier because they're finally getting the fruits of all their effort of when they're learning because they've been trying all along. But if your brain is more like this with taking sound in than a sponge, it's pretty self-defeating. And then finally, central auditory processing disorders does even have a ICD-9 code, 10 code being recognized. So this I can give you in a PDF. This is just a behavioral checklist of symptoms for CAPD. So I just briefly went over it in the interest of time, but my email will be at the end. If you want me to just send it to you, I can send you that behavioral checklist. Keep in mind, though, that symptoms are not, which I think symptoms are not diagnostic. And the symptoms for ADHD and the symptoms for CAPD are very similar. So that it's good to know, and that kind of can, again, plant a little tickler in the back of your mind of, well, would this child be an
Dr.
appropriate referral?
Abramson, I think Dr. Bernstein has a question for
Oh,
you.
yes, yes.
Have you ever used the COPES scale, COPES, that they have at Rutgers? I've been using that for the past few years, and it is amazing how when you ask, basically parents, it's a parent scale, do you have to repeat when you ask a question? Does your child not seem to understand when you say it out loud? Wow, you just get so much information if you can ask the questions that nobody asks.
That's an excellent point. I'll go look at it. I haven't used it, but I think that exactly if you ask that question, and even adults that I see that have weaknesses, that have deficits, I'll say, "How did you learn in school?" And they'll say, "Oh, well, I was dyslexic." I'm like, "Oh." So, yeah, just kind of opening the lid here to see what's inside is an excellent point. So this, in the 90s, everybody wanted to have a diagnosis of CAPD. So I made a little triage chart. So to do auditory processing tests, they're challenging. So you need to have a normal cognition. And I usually look at the child's speech and language evaluation, any academic problems. I look at their psychoeducational evaluation. And the fact that they could have a test. You know, I have one now where I have to review a case about this many records to see if the child can actually be able to be tested. I see about 5 lawsuits a month where parents are suing the school district because the child isn't making the progress usually in reading. And so I usually use age 7 for a cutoff on a lawsuit, but I am a firm believer in early identification. And I mean, I wrote the test that can start at age 4. So if you have proactive parents that suspect something, you can definitely start at around 5, age 5, depending on the social maturity of the child. So this is the short story elevator symptomatology. These are 2 key questions for a referral for central auditory processing. Remediation resistant. That means the child is trying their best, but they're just not making the progress that you would expect based upon their intelligence and the intervention. Okay. So if they have good intervention and you have a child who has the intelligence and the motivation and they're not making progress, again, you should think, there's something else. And maybe it is auditory processing and look into that. And the other big key indicator is difficulty hearing in quiet. A lot of people have trouble hearing in noise, but I will see sometimes, and I don't know, Dr. Bernstein, if you see this too. I mean, in quiet, like they'll turn up the TV because they feel they can't hear it, even though their peripheral hearing is normal. So the comorbidities associated with central auditory processing. On this left-hand side here, I've listed what tests I see that are usually not in the normal range. And for example, for attention deficit hyperactivity disorder, I will see difficulty sometimes with pitch pattern perception. Now, how we do that in the brain is on a 3-tone pattern like da da da, the right side perceives that as music. But for you to say those words, low, high, low, it has to cross the corpus callosum and come to the left hemisphere for verbal expression. And so Hind in 1990 looked at the brains of children with ADHD and CAPD and found that the part of the corpus callosum that transfers auditory information is also responsible for attention. So this means that ADHD and CAPD, at least in the corpus callosum, share the same neural substrate. So that's why evaluation is really important. And children on the autism spectrum can have these types of deficits with auditory processing. I changed my mind and started doing auditory processing with children on the autism spectrum after Nina Krause's work, and that was in the late 90s. She's a neurobiologist at my alma mater, Northwestern. I know there was somebody from Chicago in there. What she found was that when she did electrophysiology studies looking at a speech sound going to the top of the brainstem, for children on the ASD spectrum, language learning disabled, and also on the ASD spectrum, that speech syllable took a little bit more time to get to the top of the brainstem. Now, that's not a behavior, that's electrophysiologic evidence. And so if children with ASD are wired differently, which we know they are, then it's incumbent upon us to see if we can try and improve that for them. And then again, my thesis advisor, Pat Kuhl, did an electrophysiology study with auditory discrimination and indicated that children with on the spectrum have difficulty with auditory discrimination, and they can be hyper or hyposensitive to sound. Kujala in 2010 also noted that children on the spectrum have difficulties with discrimination. So
I wanted to bring up one thing that you brought up, Dr. Abramson, real quick, if you can go back to the slide. But, our folks on the spectrum also speak in a monotone voice, right? And they don't pick up inflection in other people's voices, which is part of their difficulty in perceiving emotion. So this really speaks to, and I've seen it in patients that once you treat the CAPD, they actually become a little bit better in perceiving and actually having some more inflection in their own voice.
Right. Yeah, that's a good point. I mean, if they have that as a deficit, I wrote an auditory training program to fix it called Basic Auditory Training, affectionately called BAT. But one of the training, Batwoman, one of the training mechanisms is to have the child hum patterns and generate that from within them. And yeah, Dr. Contractor brings up a good point. Oftentimes, again, it just is not perceived by them. With regards to reading, I never thought I would be into reading, but oh, yes, I am, because a lot of children that have dyslexia have auditory processing problems. And the developmental sequence of language learning is hear it, speak it, read it, write it. So the auditory processing is fundamental to everything. And so this is definitely, we look in audiology to go beyond the audiogram. I mean, the audiogram is, do you hear the tone or not? That's the peripheral system, but we all know that we hear with the brain. And so with reading, this basic sensory information of pitch change and this pitch contour, that has to be on the superhighway of processing, because if it's not, you're slowed down in treating the content. And so this was published in 2007 that we need this basic sensory information for reading. In 2003, pitch contour, or hello without the word. So Dr. Sharma in 2019 noted that the poorest readers in her study had deficits with pitch patterns and pitch discrimination. And also how you're wired on the spectrum here. The left hemisphere is dominant for language, but I do see in some children on the spectrum, or say maybe a child with pediatric stroke or whatever, if the right hemisphere is dominant, then of course language learning is going to be more laborious. It's your non-dominant hemisphere. So this is an interesting slide because if you see children on the spectrum, you know that they do have sensitivity to sound. And I don't know how they made rats be on the spectrum, but they did. And what's interesting here is in the medial nucleus of the trapezoid body, which if you can see my pointer right over here, in the control rat, this little blue arrow is suppression. And so sound is, and this is just low level in the brainstem, sound is suppressed. But in the hypersensitivity model, this suppression is not happening, and therefore sound is louder. And you see this, you do see that sometimes children on the spectrum have this hypersensitivity to sound. And you might also see this with misophonia as well. I thought it was interesting because it shows the electrophysiologic model. This is showing you that reading is an auditory-based skill. So here you have a deaf population, which we don't have so much anymore. This is an old slide because deaf people, a lot of them get cochlear implants now, and they hear quite well. So, but traditionally, if you're deaf with no auditory input and here you have hearing, you can see that with age, your reading improves because your auditory skills improve. So this is a pretty telling statement with regards to the impact of auditory processing. So if we have a deficit with auditory processing, can we fix it? And the answer is yes. Goody for us, right? And so your poem on the seeds is like so perfect because these are the seeds to improve, help improve people. And it's just such a great privilege to be able to present this to you. So in intervention, we basically have two categories, either do auditory training or provide remote microphone hearing aids. So let's go through these just briefly. So for discrimination would be AA versus A versus B, like dee or da-da. So we have what we do is make deficit specific auditory training programs. We're going to treat discrimination, or we're going to treat pattern recognition with the basic auditory training program. So we have specific therapies for specific deficits. For binaural integration, we do dichotic therapy, which means that you're going to hear two different signals at the same exact time. Dr. Frank Music, who's like the father of audiology, developed the dichotic interoral intensity difference model. And from that, Dr. Moncrief made this oral rehabilitation of interoral asymmetry. It's like my first name without the M. Uh, and it's the difference between the ears. So as we mature, like for all of you, your right and left hemisphere communicate rather effectively. But if you have your right hemisphere way down here, the main idea is way down here, and your left hemisphere is high, this is hard because this takes time. Okay, you have like a 7-year-old trying to play with a 12-year-old. They don't play that well together. So this intervention is conducted in the sound field, and it has both excitatory and inhibitory influences because we make the dominant ear softer and the non-dominant ear louder simultaneously until we can improve the non-dominant pathway. So that's a very effective therapy that I do in my office. It's a total of 6 visits. It was published in 2016, the types, and then in 2017, the efficacy was published. And it's pretty effective, 0.01 level of significance. So that's a useful therapy for that, and it treats binaural separation as well. Temporal ordering and sequencing, I wrote that basic auditory training program for that. And then these last 3, auditory figure ground, which is listening and noise, auditory closure, which means the word is a little distorted, and temporal processing. I should slow down, I know, and fast speech. All of those can be effectively treated with a remote microphone hearing aids. As a matter of fact, in another month is another national Zoom presentation on that if anybody's interested. What audiologists do is we fit very mild gain hearing aids, open ear, so you can hear all around you. And the speaker wears a microphone or a transmitter. And the distance from the mouth to that microphone is like your Jiminy Cricket in the listener's ear. So therefore, the negative effects of distance and noise is a non-issue anymore. And but the other, so that will treat auditory figure ground. But use of these instruments also has a therapeutic effect in that the 8th nerve will deliver a more consistent signal to the brain. And what I liken it to is if you think of these, the remote microphone hearing aids as kind of like training wheels for the 8th nerve. You know, when you learn how to ride a bike, you need those wheels, but then as soon as you can ride, you're on your own. It's the same idea. The brain goes, oh, I like this signal better. And eventually, for many children, they don't need to wear the devices in perpetuity, maybe 1 or 2 years, it depends. So these are some positive outcomes that we've seen with central auditory processing. So on the left, I have the student, and on the right, I have what happened. So this was a child that had a diagnosis of autism, speech and language difficulties, a 9-year-old boy, and he did participate in ARIA. And as Lila said, lo and behold, his IQ went up 30 points. I suspect he always had that IQ, but it just was never able to be expressed. This is another one where a child extremely anxious and was not able to hold a conversation. And huge asymmetry between his ears. And the mom wrote me a thank you note that when they were finished with ARIA training, that they could have a conversation with him. And a lot of his anxious behaviors were reduced. This other one is the little girl. Oh my gosh, she would just cry, and she was just like a wilted flower, and boom, she bloomed like she got sun and water. And mom wrote a very nice thank you note about that. So that's just in general. This is a specific case. So this is a 9-year-old boy on the autism spectrum with language impairment, no intellectual impairment, and a specific learning disability in reading and math. So that means there's a 22-point discrepancy between his intelligence and his academic performance. He took Vyvanse with no changes, and inattention was still noted. So he had deficits with binaural integration, using both sides of the brain together, separation, being able to suppress unwanted stimuli, and temporal processing. So I treated him with ARIA. That was the sound field dichotic training. And on the right-hand side there, kind of towards the bottom, you can see before his left ear was 13%. It improved to 64%. So he was in the normal range there. The right ear was 70% pre-treatment, and it went to 82%. I didn't treat that ear, but it just improved anyway. And because it's dichotic, it's getting stimulated. So essentially his scores were normal. And look at that intraoral asymmetry from 57% to 18. Much more efficient processor for auditory information. Now, wearing devices, a lot of people don't want to wear hearing aids. And a lot of kids on the spectrum have sensory defensiveness too. So this was in his case also. And I go through trainings like how you learn every year, right? So I have a BCBA train me of things that I'm interested in. And I said, well, how am I going to get him to wear this? And so his school was very supportive as well. And just he had like a positive behavior program. It would just be on his desk, then he would touch it, then it would touch his cheek. I mean, it was a slow process. But we're making progress. And so, his reading has gone from the first to the fourth or fifth grade. His math went from the first to the third or fourth grade. So we're looking good. We're going in the right direction. And finally, he's starting to close the age and grade gap.
Dr. Abramson, I know we're gonna have to wrap up in just a minute.
Mm-hmm.
Is it okay if I ask one question that I think is probably on everyone's mind so that those who need to run can hear
Sure.
it? So
Sure.
how do we find somebody local? Because we're all over the country.
Oh,
How do
here.
we find somebody that's good?
Okay, so here you go. So Jennifer Gonzalez, is Mayo Clinic near you in Scottsdale?
All over. So we're in Texas, Arizona,
Oh,
California.
oh,
There's some
okay.
sort of directory that one can
Yeah, well, we're working on that directory. So if you email me, I will try and find somebody in your state. Yeah. Because it's a small group. There's not that many audiologists that are well trained in that. So I just go back, I'll just finish up. So yeah, so if you email me, that's the group for Arizona, and uh, I think Chicago, I'm sure I can find somebody for you in Chicago. So just briefly, you see how there's neural noise here? These light waves don't line up on each other, and here they do. That's just by wearing that remote microphone hearing aids. So that's really a great intervention. Here, this is the dichotic model for listening. So the right ear goes to the left hemisphere, the left ear goes to the right hemisphere, and the corpus callosum joins the two. These little yellow areas are the auditory cortices. What's important to note is they fight for dominance down here in the brainstem. So that's our structural model for dichotic listening. And so the correct diagnosis leads to correct treatment. And Lila, I just want to, Dr. Contractor, if you wanted to present this case, I think we can wrap it up.
If we don't have time, it's okay, Amelia. I totally want to respect
Go ahead.
everyone's time.
In a minute or two, I think those who
Yeah, so this
they
was
will
a
say.
patient that I referred to her, presented extremely depressed, actually had a history of psychotic depression. And anyways, I got to know her. She had not been diagnosed. I saw her about a year I first met her a year and a half ago, not been diagnosed on the spectrum, kind of your typical girl who gets missed, had ADHD, and also misophonia. And as we were trying to get the mood stuff as well as the ADHD in order, I sent her to see Dr. Abramson. And sure enough, Dr. Abramson, you can take over some of the things that you saw. And I actually suspect her IQ is much higher than this. I actually think her CAPD, ASD is inhibiting. She's an excellent student, really brilliant.
Yeah, at first, I thought oh, okay, she's like a misophonia type of patient just with sound sensitivity. And when I evaluated her, I was like, oh my gosh, look, she's in the first percentile for binaural integration. She's in less than the first percentile for temporal processing, first percentile for binaural separation, second percentile for listening and listening in noise. So I asked her, how do you learn? Because she's got all good grades. She goes, I don't learn anything in school. And she doesn't qualify for an IEP because she is smart, right? Intelligence forgives a lot of sins. So, this is not a typical treatment for misophonia, but it is in her case because she's got so much sound going in that she can't sort anything out. So I made custom made musicians earplugs for her, and that's relieved her ability to be in high school, which is noisy all around her peers. But she also needs to have remote microphone hearing aids, and she needs dichotic therapy. I think the family is overwhelmed as to where to start. And so she's kind of a case in progress right now. She's been significant, but they need a little bit more direction to keep going, you know. And I know you're encouraging them, right, Dr. Contractor? So with that, I just want to say thank you. That's your referral base for Arizona. And I just wanted to